affected. We should note that when we are talking to somebody, the person is aware of the environment. When you talk of the orientation, we can talk of which place are you, which country are you, which location are you. The person is still aware of the environment, and the person is also is alert. So the disease condition doesn't affect alertness and also attention. So we can use this one to distinguish dementia from a disease condition like delirium or any other memory loss that might mimic dementia. Talking about the epidemiology, as at 2023, globally, dementia account for 52 people, 55 million people who are affected in low and middle income country. But as I'm preparing this slide, what I read from the literature is that we have 57 million currently. Then in Africa, we have 47 million people. And in sub-Saharan Africa, maybe due to non-reporting the seriousness or severity of the condition, only 2.76 million people are reported to be suffering from the condition in sub-Saharan Africa. So can you help me go to the next slide, please? Next slide, please. Hello? Next slide. Next slide. Okay.
I'm on the next slide now.
Okay, please. Thank you. Yeah, when we compare dementia with other disease conditions that affect daily activity, that affect life years, dementia is accounted for 9.5% when you compare it to musculoskeletal disorder, cardiovascular disease, and cancers. Musculoskeletal disorder is 8.5, cardiovascular disease is 5, and cancers account for 2, according to a report by FIMAT of 2019. So many patients are undiagnosed because most health workers are not aware of the blood tests. We call them blood biomarkers that can help us diagnose the dementia condition early. And we have many biomarkers that we are trying to establish in blood to help us in early diagnosis, particularly our routine blood biomarkers that we use for screening cardiovascular disease condition, like the lipid profile, then the food, and some things that have to do with the hormone, particularly the thyroid hormone. Most of them have been established to help us in diagnosing dementia. Also, deficiency of some vitamins like vitamin B12 and the folic acid can also help us. Then you can also use laboratory tests to exclude dementia. Please, next slide. Next slide, please. The slides are not moving. Can we go to the next slide? Hello? Yeah, thank you. Yeah, looking at the causes of dementia, particularly the disease condition that has the highest or that have been linked to cause of dementia is called Alzheimer's disease. And we have said this about 60 to 70% of people that have Alzheimer's disease that come down with dementia. And we know Alzheimer's disease is related to old age. So we have people who are suffering from Alzheimer's disease, particularly once they are 60 years, they start to manifest the symptoms of dementia. And we know Alzheimer's disease has to do with the accumulation of some tau protein and neurofibrillary tangles in the neurons. So old age, anybody that is 60 years and above, and when we look at the risk factors, if the risk factors is present or are present, so they are likely to come down with dementia. Then we have also seen that people suffering from some cardiovascular disease condition, particularly stroke, heart diseases, they come down with a type of dementia called vascular dementia. Then when there is trauma or injury to the brain, that one is also another cause, particularly those that are having some sports that are combat sports where the head is not protected, like boxing and taekwondo, judo, those that are not covering their head with some protective elements. So when the head is bugged or when there is injury to the head, so that one too is one of the major cause. Then we have infections, particularly HIV and syphilis. So we have neurosyphilis, which has been established to cause dementia, and also HIV. Then there is a infection of some bacteria, particularly E. coli, that has also been established. There are other conditions too, bacterial infection, viral infection, that have been linked to cause dementia. Then hormonal deficiency like thyroid hormone, the T3, T4 hormones, when they are deficient, they can cause dementia. The other issue which has not been addressed properly is the issue of depression. Now, depression is on the rise. So, depression is a major cause which has been established to cause dementia. Then we have some other disease conditions like the Parkinson's disease and the Huntington's disease. So, all of them are for the signs and symptoms, so we can classify them to mild, moderate, and severe conditions. So they are graded using some dementia diagnostic tools or cognitive uh, detection tools like the MMSC and the BDS. The MMSC is Mini-Mental State Examination Test, and the BDS is Blessed Dementia Scale Examination. So these tests make use of memory recall. So talking of the MMSC, you call some information to the suspected sufferer, and you ask the person to recall. So if they can recall it, there's a way you score it. Then also for orientation, you can ask the person, where are we, which week are we, which day are we, which room are we. So you check if the patient, if the sufferer can identify where the person is located. We can say which month are we, so you can use that. Then you check attention as a continuum. You see if the person is conscious. Then you also see if he's in a coma, in a stupor, or is not responding. You can check attention. So those are the signs and symptoms. Then based on some activity of daily living, you can check the feeding habits. Hello, can you see me?
Yes, we can
You
hear
can
you, sir. It's
I can't
6,000.
I can't hear you.
We are hearing you. We are hearing you.
6,200
Okay, thank
everything.
you. But from my own slide here, it's saying there's a problem. You have. Okay, let me continue with the other gadget I'm using. So when you look at activity of daily living,
6,000.
particularly feeding, you check if the patient can feed himself, what kind
Money
of
point.
food the patient can eat. Maybe it's only solid food the patient can eat. You can use that to check the severity of the condition. Then the toileting habit, if the patient can feed himself without
Àárọ̀,
being
ẹ̀kọ́
fed.
lójúmọ́ ni bọ̀ tó wá pé àárọ̀ ló
Then
dáa
you
jù.
check if the patient can
Ó mọ̀ ọ́
locate a familiar place if he leave the room, if he can get back to locate the room. So all those are the things you use to know the severity of the condition. Okay, please, next slide. Yeah, talking of the risk factors, we have some factors that are said to be modifiable risk factors, and we have some that are non-modifiable risk factors. Of recent, anemia has been established to be a modifiable risk factor. Also, we have the cardiovascular disease condition like diabetes, hypertension, heart disease. All those.
We can't hear you again.
So talking about these factors, pesticide and heavy metals, we see that most of our agricultural products are laden with pesticide. So during the cultivation and harvesting of the agricultural products, heavy metal, particularly lead, have also somebody been to lead. That man has also been established to be a risk factor. Then some other chemicals and use of drugs that are not prescribed risk factors. Then we have other environmental risk factors, like somebody living in the slum and where there is air pollution. These ones have been established to be linked directly to dementia. And for the non-modifiable risk factor, we have age, gender, genetic makeup, adverse life event. Some people are so unfortunate that they have so many adverse life events. Even when they are growing up, they lose their parents, or when they are adults, they lose their children. So many other unfortunate situations. So those ones also have been established to be.
How many days? Emergency. Ọ bụrụ na ihe na-agba once in a day, nke a morning night. Ị ga-enweta nwere emergency.
The slide is on display. Dr. Salam, we can't hear you.
Oh, ṣe ìgbéyìí.
Dr. Salam, we
Sorry, please.
cannot hear you.
Okay, please, can you hear me now? But there is echo.
Yes.
Because if I try to off one of the gadgets, the two of them will not be speaking again.
The slide is on display. You can use the display.
You did drink. It's time to back.
Okay. Now I'm on table 1, telling us about our findings using the social demographics of the participants. And when we compare the male and the female, we can see that there is no significant difference between the male and the female. And the interpretation of that is that whether you are a male or a female, it doesn't matter. Both male and female gender can come down with dementia. And when we compare the ages between 60 to 100, when you compare them to those who are 50 to 59, we also see that there is no significant difference, meaning that dementia can happen in any age from age 50 and above. Because we selected our participants, we have 156 participants who are age 50 to 90 years. Going to educational attainment, so we see that there is a significant difference. The value we got is significant, and at the level of higher education, somebody attaining tertiary education, and when you have that negative value, is telling us that once you attain tertiary education, you are less likely to come down with dementia. So part of the suggestion for this study is to encourage people to pursue higher education. And looking at the marital status, we look at those who are divorced, who are separated, who are single, and those who are widowed. So it's telling us also that there is no significant difference. Looking at religious activity, also no difference. Looking at residents, when you look at people living in the urban and people who are living in slum, so there is no difference. But interpreting this value, we see that those who are living in slum have 16 times chance or likelihood of coming down with dementia. That is the interpretation of the values we got there. Then living with family and people who are not living with family, we see that also the values we get is significant, telling us that people who are living with family might not come down with dementia. And we also realize that living with family means you are not living with toxic people, you are not living with somebody who is stressing you. So from the social demographic, we see significant value we got is from education and living with family or relatives. So my slide is not moving. You can help me go to the next slide, table 2. Yeah, thank you also. So table 2 is talking to the risk factors, and the values we present here are the risk factors that are attributable to dementia. So when you look at the column for p-value, we can see that if somebody has heart attack, it is significant, and it means that somebody that has heart attack has about 9 times chance of having dementia. That's the interpretation of the value there. And when we look at somebody with a stroke, we see that that is also significant. And the interpretation is that somebody that has a stroke has about 2 times chance of coming down with dementia. So that's the interpretation there. So when we now look at other factors, we can see they are not significant, but it's just telling us of the chances of the people coming down with dementia, particularly when you see somebody using a drug for high cholesterol level like statin. You can see we have this 0.63 values telling us that they are less likely to come down with dementia. That is, even if somebody has high cholesterol level and is taking statin, is protective, it's not likely to come down with dementia. Likewise, somebody who can still think and somebody who can utilize his memory. But if there is memory loss, we see that that one is significant, and where the value is 2.96, that's about 3. And we say the interpretation for this is that somebody that has memory loss has 3 times likelihood of coming down with dementia. So those are the interpretation. But if somebody can still do daily activity, we can see the value there that the person is not likely to come down with dementia, and somebody who can still control his behavior, can still behave well. So that is not waste our time. That's the interpretation of the value. But talking of the significant value, we have somebody with heart attack, somebody with stroke, and somebody who has memory loss. Those are the significant value that have been linked to dementia. So those are established according to our finding to be the risk factors for dementia. So next slide, please. Yeah. Now we have to think of how do we prevent dementia, or what are the protective factors. Issue of sleep is now a major concern because it has been established to cause dementia. So when we want to sleep, the place we sleep, from some other studies, they have recommended that the room we sleep should not be well lit. Maybe there should be a dim light, or we even off the light totally when you want to sleep. There should be no television in the room we are sleeping, and there should be phone, no phone in the room we are sleeping, and the room we are sleeping should not be hot. If there is phone in the room, the rate at which the phone beeps will affect our uh, ROM, so we not have a deep sleep. Then the light that comes, maybe through alarms or through the light that just come from the phone also will prevent us from having a good sleep. A good sleep has nothing to do with how long we can sleep, but it's the quality of the sleep. There is this melatonin that is produced during darkness, so which has been adapted to good sleep. But if we put the light on, we'll not be able to sleep well. Then there is this diet we call Mediterranean diet. It was established from the people living around the Mediterranean Sea, but it's not necessarily only those people that can have Mediterranean diet. What they describe as Mediterranean diet, particularly when you are above 50 years, is a food that is less in carbohydrate, less in carbohydrate, less in fatty substances, and less in dairy products. Less in carbohydrates, less in fatty substances, less in dairy products. But it's rich in vegetables, rich in fruits, rich in nuts, rich in cereals, rich in olive, what they call omega H3. So that's how we can establish, even when we have it in Africa, yeah, it's still Mediterranean food. Now, talking about the management of dementia, my co-presenter is going to talk extensively on the use of medication. But what I intend by management of dementia is when somebody has the symptoms already and is already presenting with the signs and symptoms of dementia, what do we do? Do we just fold our hands? So my colleague is going to talk about the medication. But apart from that, we should encourage the person that is presenting with the symptoms to do his daily activity himself. Let him try to feed himself, go to toilet himself, where his clothes is himself or herself. We observe that people that are suffering from dementia are not allowed to do this activity by themselves. Then there are some other special activities whereby we encourage the people suffering from dementia to do, like this professional meeting we are having. We should encourage them to participate in professional association meetings. Then political, tribal, and religious meetings, we should encourage them there. Then living with family and relatives, we should encourage. We have what we call empty nest syndrome, whereby we build big houses, our children are living abroad, so only the husband or the wife is living alone in a big house. So I know most of us are observing that. Then exercise, particularly walking and swimming, whereby we can utilize all our body. So we should encourage that. We see that many people that are suffering from this condition are always bedridden. They are not allowed to do exercise. They say they don't want to disturb them. Then physiotherapy, physical activities, and mental activities. So we should encourage them to do to attend physiotherapy session, also do physical activities. That is why it's different from exercise. There are also mental activities. You let them play music, learn language, learn all these mathematical, anything that can tax the brain. We see that most of us utilize our phone just to for enjoyment. We don't utilize our phone. We don't we utilize our brain again. We just utilize the phone to help us to do even any simple mental sum. So that one should be discouraged. Then there is psychosocial support. There are many clinics and many groups now advocating for dementia. So we should not hide them in our homes. We should allow them to go out and meet other people who are suffering from the condition. Then at that stage too, they need family support. There are some behavioral changes we see in dementia patients whereby they need their family support. They might be aggressive, they might, so they just need that warmness from the family. Then anybody with cardiovascular disease condition like hypertension, diabetes, and depression should treat. The stress also should be reduced. And also we mentioned Mediterranean diet. I think I should stop there and invite my co-presenter to talk about the management. So after that one, we come back to take home message. What have we learned from today's presentation? Thank you so much for being patient with me and for your attention to my presentation. I'm so sorry for coming late. Thank you so much. So my co-presenter, Dr. Sulaiman Ademola, please, over to you.
Good morning from here, everyone. Can you hear me?
My What do you say?
Hello. I
Yes,
say
we
good
I'm
can hear
hearing
evening.
you. Good
Good
evening.
morning from here.
you. Yes, we can hear
Okay.
you.
How's it going?
Yeah. Um, just like my colleague has said, Dr. Salam, and I'm sure that we have had the basis. My intention is just to run through the medications that we have used in the people that are actually going through the clinical trials. And let me also say that we will not be able to show so many data because the donors still actually are supposed to have the final result before it is being presented to the population. However, what we have observed while those drugs were being used, we shall share it with you, and hopefully, because the intention of the research is to get three things done. One, to have a protocol management that we assist the dementia people, not only in terms of management, but if there is any possibility of reversibility of continuous neurodegenerative activity. The second one is also to encourage early detection, because it has also been observed that there seems to be some improvements when the dementia is detected early, and the management are initiated almost immediately, compared to those that they have been in denial, or there is a misdiagnosis, and by the time we got to know that this person is suffering from dementia, it is almost too late, and the medication given actually do not really have much effect on them. So, like I said, I shall run through those drugs that is being used from the perspective of our research. Hello, hello, can you hear me?
Yes, please, we can hear you.
We can hear you.
Okay. Did you hear my preamble?
Yes.
Okay,
We
Yes,
we had it.
we can do.
okay. It is all about cognitive memory, and that is all that has been implicated by the loss of cholinergic activity. We also know as pharmacists that one of the first line drugs that has been used in this management is cholinesterase inhibitors, especially the donepezil, the rivastigmine, and the galantamine. These were actually being also used in those three categories. They control the early detected dementia and the late dementia patients. So this drug actually improves the cognitive function by increasing the availability of the acetylcholine that is involved in the learning and memory. The results actually show that they all improve the memory of the patient, but no appreciable, and there seems not to be more beneficial to, and it actually seems to be more beneficial only to the early detected patients. The use of antidepressants is that, just like my colleague said, any patient that you actually say that you have the dementia, you will see that in the next visitation, they will definitely come down with depression. when you look at whether there is any synergistic activity between antidepressant and then the other drugs, you find that antidepressants do not give any advantage to a dementia patient. The depression can worsen the cognitive impairment and it can reduce the quality of life. So treating patients with antidepressants does not necessarily mean that it actually going to assist the 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 continuous neurodegenerative activity. The selective serotonin reuptake inhibitors, the serotonin non-epinephrine reuptake inhibitors, even the atypical antidepressant or the tricyclic antidepressant, none of them actually shows better improvement in dementia management, irrespective of aside that they actually assist the patient in a depressive activity. But in terms of whether there is improvement in the cognitive activity of the patient, they actually do not. None of the class benefit the improvement of the dementia condition in the patient. However, they show important supportive role in dementia management by treating depression and behavioral symptoms. So they only improve the patient emotional well-being and quality of life. But in terms of the management of the dementia, none of the antidepressants actually show promising. So another drug that we have also seen that actually shows some benefit to dementia is nematinib, which is a NMDA receptor antagonist. We know that glutamine is CNS excitatory neurotransmitters, and one of their major side effects is that they can cause neurotoxicity, especially when there is upper activity of the neurotransmitters, which we can also use NMDA receptor antagonists to actually reduce the excitatory activity of the glutamic neurotransmitter. However, it did not actually improve the late detected dementia patients. Yes, it has some improvements when it comes to the early detected dementia. So the results have actually shown that and the reversibility does not stop. It does not prevent the continuous loss of neurodegeneration and the loss of the neuron. So patients after some times, you will see them, they still come back and they come down with the same symptoms that you have seen in them when you probably start with them from the week one. So the other class of drug that we also got information about the use in management of dementia is NSAID. So the following drugs were actually used: ibuprofen, indomethacin, diclofenac, and celecoxib. However, the only one that seems to show reasonable benefit is ibuprofen. Celecoxib being a COX-2 selective does not even have any activity. So NSAID is known to exert anti-inflammatory activity, and dementia is associated with inflammation, which is believed to have contributed to the development and progression of the neurodegenerative disease, especially dementia. It is only patient on ibuprofen 400 milligram twice daily for 10 days that shows slight improvement in memory and cognition. This improvement is seen only in early detected dementia patients. However, those that have been denied that they were detected later in life actually do not benefit from the ibuprofen as seen compared to early detected dementia patients. Another class of drug, calcium channel blockers, he has also shown to have some activity in dementia. However, among the calcium channel blockers, the only one that seems to show appreciable results is nimodipine. Nifedipine and the amlodipine did not show any benefit. So we know that the calcium channel blocker was considered due to the role of calcium ion, because abnormal calcium regulation in neuron is believed to contribute to neuronal damage and cognitive decline, particularly in vascular dementia. Calcium ion played an essential role in neuronal signal, neurotransmitter release, and the memory formation. In dementia, calcium channel entry into neuron can cause neuronal toxicity and can lead to cell death. This actually contributes to cognitive impairment and neurodegeneration. However, the calcium channel blocker help by reducing the calcium influx into the neuron and also improve the cerebral blood flow. The results shows that it is only the nimodipine, a dihydropyridine calcium channel blocker, that actually shows good penetration into the brain and improve the cerebral blood flow. Patients show indifference with those without calcium channel blocker when compared with other calcium channel blockers such as amlodipine and nifedipine. So the only one that shows some appreciable effect is nimodipine. Amlodipine and nifedipine, compared to the control, and there's really no difference. There has also been use of turmeric, uh, uh, curcuma longa, in dementia because of the active ingredient, which is bioactive compound curcumin, which is an anti-inflammatory, antioxidant, and a neuroprotective drug. But this has actually shown some beneficial in dementia disease. However, the use of turmeric on the patient have shown improved memory and the cognitive function on both early and late dementia patients. But one of the major problems associated with this is that we have not been able to get acceptable formulation for the standardization. So when you increase the dose, you see an improvement. When you reduce the, so we have not been able to get to the standardized dose and the standardized, acceptable formula, because it also has a problem of absorption. So that is also one of the problem. But turmeric is also one one compound that actually shown that it can help in management of dementia. Another one is ginkgo biloba. So it is one of the herbal therapeutic options for improving cognitive function, and it's also shown to have slowed down the progression of cognitive and the decline, particularly in vascular dementia. The extract is from the leaf, which contain active compound, and the flavonoids, which possess antioxidant property, and the terpenoids, which is known as gluconide and bilobinide, which also has neuroprotective effect. The patients that were placed on this extract were seen to have improved, highly improved if effect, and this actually is also seen in both late and early detected dementia. However, one of the problems that it is highly expensive and may be out of reach for most patients, and we have been told that most of the people that actually will come down with dementia were people from poor background or people from the village. So vitamin B12 is also being implicated in the use of dementia. However, we find out that the deficiency in vitamin B12 can lead to cognitive impairments and neurological damage. Therefore, correction of vitamin B12 deficiency may improve or prevent cognitive decline, especially in some form of reversible dementia. Severe deficiency may mimic dementia or worsen the disease symptom. However, in established dementia disease, vitamin B12 is not beneficial at all. So we only seen vitamin B12 being useful when the patient has vitamin B12 deficiency, not that when the patient do not have vitamin B12 deficiency and it's a dementia patient, vitamin B12 does not confer any benefit to such patient, whether early detected or late detected. So none of the patients have appreciable improvement when placed on vitamin B12 except if they have vitamin B12 deficiency. So use of psychosocial intervention were also analyzed, and being a non-pharmacological strategy is also used to improve the psychosocial, behavioral, and social functioning of the individual with dementia. There are there are about two that we actually employ: the use of music and physical exercise, and it has shown to have improved the condition of the patients. However, they did not stop the progression of the disease. So psychosocial intervention are essential components of dementia management. They complement pharmacological treatment and significantly improve the quality of life of the patient. In conclusion, the management of dementia requires a comprehensive approach that integrates pharmacological treatment with psychosocial intervention. While drugs such as donepezil and nemartin remain the first line of the treatment of the dementia, effective dementia management requires a multidisciplinary approach combining pharmacological treatments, psychological support, and management of comorbid condition may improve patient outcome and quality of life. So these are my references. Thank you for listening.
No problem.
My PI is ready for questioning. Me, I'm just a supportive. Thank you. Hello.
Yeah, thank you, Dr. Sulaiman. So we are waiting for questions before we go to the take-home messages.
Hello, Mr. Moderator. Somebody can take over while we wait for Mr. Moderator. Hello.
Hello.
Hello, who is moderating?
Dr. Rita, can you step up? Dr. Rita, please.
Okay.
Dr. Tini. Okay, thank you.
Okay, good evening, everyone. Thank you very much, sir, for the wonderful presentations and the lecture on management of dementia from perspective of research. So it's time for comment, contribution, or questions from our listeners and participants.
Hello, Richard. Somebody's hand is up. Professor Chukwe's hand is up.
Okay. I can't see the hand raised from my own end. So please unmute yourself and make your contribution or question. Thank you.
Thank you,
I didn't
Prof.
hear me. Good evening, everyone.
Oh, Prof.
Good evening,
Good evening,
Prof.
Good
Prof.
evening.
Good evening. Yes,
Good
ma'am.
evening. Thank you so much, Dr. Sademola and the other presenter. This is very timely, and many people now have undiagnosed dementia. And many people now think it's a spiritual matter. So I think I have one near me, and they didn't manage it. They didn't think it was something that is feasible. And they were thinking going to traditional houses, using traditional medicine. I think it is part of ignorance. And this presentation is very apt at this time. Pharmacists should watch out because so many people have dementia undiagnosed. And from the presenters, I can see that early detection helps the prognosis. Thank you so much for this wonderful presentation. My question goes to, I don't know whether the two of you are one, mixed dementia. I have a patient, in fact, my own blood relation, who has dementia, and the diagnosis, definitive diagnosis says mixed dementia. And I'm told that this patient had stroke. The family did not take the patient to the hospital. And then she had this dementia. Right now, the patient does not talk. I don't know how long now. So from this presentation, the consultant, the neurologist is saying, start and continue physiotherapy. But I don't know whether they are doing it or not. I know that physiotherapy can help because I have had a patient who had, the patient does not have dementia, but had stroke. But due to the physiotherapy, the person gained cognitive activity and started talking. But this particular one that has dementia, up till now, is not talking. It's bedwetting. So, Dr. Demola, I think this question goes to you. What do you suggest they should do? The physician is saying continue physiotherapy, but still, for many months now, the patient still does not talk. I don't know whether you can suggest anything. Thank you very much.
Okay.
Should I answer
Thank you,
it,
Professor.
or I wait for others? And
Yes,
then
I have
and
to,
then and then Dr. Salam can start.
yes, I have to have a shot at that. So thank you, Professor, for the question. It's of recent that WHO declare dementia as a public health concern. As I told you earlier on, like this year now, they have reported that there are 57 million people suffering from dementia, and the chance of it increasing is is higher now. So all of us should be concerned about it. Yeah, the question is about mixed dementia. I want to ask Professor, maybe the woman or the man or the patient is older than 60 years. So
Yes,
when the person is older than 60 years,
the
so that one
patient
can
is,
bring in
the patient is
how old is
about 69. 69.
69 years. So if he's 69, age factor, which is related to Alzheimer's disease,
I
cannot
know.
be ruled out. Then
Mhm.
since patient also has stroke, so we can also consider vascular dementia. And that's how the consultant can come with the diagnosis of mixed dementia. When I talk of mixed dementia, it's majorly between Alzheimer's disease and vascular dementia. They don't consider the other causes which I have not mentioned. There are some other conditions to which I have not mentioned due to the time limitation we had. So with that, the diagnosis might be correct. Now, what do
Yeah.
we do? That's the question. So if they have made the diagnosis earlier, possibly you might think of what to do. But the symptoms being presented now by the person concerned is telling us this is a form of severe dementia, and that is when the patient concerned cannot carry out the daily activity by himself. And one of the daily activities is talking. If you cannot talk, it will affect, it's a memory impairment. So talking is one, and that's what I also mentioned when you talk of uh, language. It has to do with ability to talk, ability to write, ability to do many things by themselves. So at that stage now, it's telling us it's getting to severe form of dementia. And also it will affect other aspect of daily activities. The person might not be able to eat himself or herself, might not be able to feed himself. So those ones will also become. Then even movement also at that stage will be affected. The person might not be able to move except by being supported. That's the essence of the consultant recommending physiotherapy and physical activities. Of recent, I've lost about 2 or 3 people in the last 1 month, and the diagnosis was dementia. And what I observe with them is they don't move the patient. The patient is kept in the room. They don't move them. And when
That's exactly what the consultant said. The patient is kept in the room,
yeah.
does not
So,
answer phone, does not do anything.
so when you're asking us what can we do, so they should get supporters, might be carers, we call them caretakers. They can employ nurses or some male carers who will be taking the patient out. If they take them out to familiar places or familiar places, if they allow them to go around where they know, so possibly they can be talking that, I know this place, I know this face. So they bring out some good memories, maybe pictures they have taken together, maybe with the wife or with the husband or with the children. When they are seeing good memories, they are recalling it, they may want to talk about it. So that one too can also help the person in regaining their ability to talk. So generally, from my experience of the 2 or 3 people, what I see that people are frustrated and people don't normally see somebody that will assist them. And we have said that in this part of the world, we still see dementia as maybe a form of bewitchment, or when God is punishing somebody for the sin he or she
That's
has committed. If they get support and people can come rally around, we talk of psychosocial support. All these are the things we need that will help the patient. Also, we should avoid stigmatization. So when we have patients like that, they don't take them to the hospital because of the way people look at the patient. So all these things are the awareness we're supposed to create, and also we support the patient. Hopefully, the patient can regain what he or she has lost. But generally, from my own diagnosis, from these symptoms we have presented, I would say the person is already at the final stage. So that is the severe part of the symptom being presented. But the people, the family, the relatives can still support. They show love. They show interest in the person. They let the person feel that the life is still worthy of living. So with all that, with my little experience, I believe the patient might come up. So that is what I can say about it. So thank you so much for your attention to me. Over to you, Dr. Ademola.
Thank you.
Yeah, thank you, Dr. Salam. I just like he has said, but I think one of the other things that could also be done is number one, you also know that the patient has some comorbidity. So, and then those diseases should also be assessed, and they should also be managed. If somebody has a stroke, if somebody has a cardiovascular disease, it should be managed, because sometimes the 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 problem may not only be dementia. If somebody is depressed, so you need to treat that person with antidepressants. So because if someone has a comorbidity and then the depression is not managed, the hypertension is not managed, at the end of the day, all those things weigh the patient down. Another thing that we have also seen from the study is also that music has also play major role to some people. If he or she is someone that loves music, you can also assist that person with that. You may be surprised that playing those old songs of what the person is known for, that whenever he
Yeah.
or she hear this, the person will come alive. You will just see the person fingers, toes moving left and right, and then the person may also be alive again. The symptomatic management should be at peak, and then both pharmacological and non-pharmacological approach strategies are to be employed. So the consultant should assess all other comorbidity and manage them accordingly.
Thank you so much. Please, these slides, I would like these slides to be shared.
Yeah, I will.
Thank you so much. The patient in question has comorbidity. The patient is on donazepam. The patient is on antihypertensive also.
Yeah. So
Thank
so
you
we
so
have
much for
yes,
your
yes,
contribution.
yeah, yes, Prof.
Bless you. Over to you, moderator.
Okay, thank you very much again, Dr. Salam and Dr. Ademola, for sharing with us your personal experiences as well as giving us more insights on how to help patients with dementia. I think so far there is no other hands raised for contribution or question. And so at this point, we are going to call for a vote of thanks. And permit me to call on our publicity secretary in the person of Dr. Timothy to please give a vote of thanks to our guest speakers for today on behalf of the national chairman, Dr. Maureen Wafo. Dr. Timi, over to you. Thank you.
Sorry, excuse me. Sorry, before the vote
Prof
of
is
thanks.
here.
Thank you so much.
Sorry, Dr. Tim, please, a
Oh,
minute.
sorry, my chairman. Oh,
No problem. She will
apologies.
still do the vote of thanks.
Chairman is around though.
National
I thought
chairman
Okay,
is here
please,
if he wants
my
to say
once
chairman,
thank
I
please
you.
over
will
to
bring
you.
my vote of thanks, I will not ask my own question. So no problem.
Okay,
Let's ask
okay,
my
okay.
question, and
Okay,
Dr. Timi
ma'am.
will go ahead
Go
with
ahead.
the vote of thanks. Okay, so I just want to
Okay,
appreciate
ma'am.
everyone here. Let me just go straight to my question. Why Timi will give us the vote of thanks? I really listened to this beautiful presentation tonight. It's a very good one, very good topic. Okay. I understand that comorbidity is a very big factor in managing this dementia because the patients we are looking at, majority of them are geriatric and are down with so many comorbidities. Okay. For me, I work in the ICU. My patients, majority of them do come down with brain injury. Okay, and they do have memory loss. Okay, so for your presentation, you made us to understand that NSAID was found to be very, very good in managing such patients. So my question is this: for such patients, in such an environment, as in critical care setting, and we don't like using NSAID. One, this particular patient is a heart failure patient, and you know that NSAID is not good for such patients. So I'm asking you, which other medication can you suggest that can be good for such patients? Another one is a hypertensive patient, has a brain injury, memory loss, and um, we do combine amlodipine and nimodipine, which you know both are calcium channel blockers. Do you think that the two combinations are very okay to use two combinations of amlodipine and nimodipine at the same time? Thank you.
Yeah, Chairman. Yeah, thank you. Just like we said, we all know the side effect of the NSAID, and we know that yes, the researchers have shown that especially the the ibuprofen seems to be the front line, though there are some others too that have also been used. And one of the things that we also normally encourage patients is that due to the chronic use of the NSAID, it can also lead to the established side effects. But we just have to encourage that patient to keep using it, and they probably accomplish it with what can ameliorate the established side effect of it. For the for the for the issue of amlodipine in combination with nimodipine in management of both hypertension and this, I actually do not know whether one couldn't have shifted to another class of antihypertensive drugs, because amlodipine is not going to give synergistic effect in the management of dementia when used along with nimodipine, and then the adverse effect associated with calcium channel blocker will actually going to be enhanced. So I would rather suggest that if any other drug, especially if amlodipine is used beyond 5 milligram, we all know the side effects of the ankle edema once it's getting to 10 milligram. So it will be better if another class of antihypertensive drug is used on that patient, except if other classes are not beneficial to that patient, or if they are not tolerable to monitor the patient blood pressure. The use of nimodipine and the amlodipine may not actually give that patient added advantage in managing both dementia as well as hypertension, but rather it could it could give that patient more associated side effects that is known with calcium channel blockers. However, any other person that has a cardiovascular activity, experience, management experience, can actually add more. But I do not think that the combination of those two CCB will give that patient a beneficial activity. Thank you.
Thank you so much for this beautiful answer. You got it. That was how I do think earlier. As I said in my facility, it has been our protocol to use these two medications, the amlodipine and the nimodipine. Earlier, we pharmacists, we are not okay with it. But when we control the management, we now find that nimodipine will just go straight to help the patient to improve his or her neurological loss.
Yeah.
Okay? Why amlodipine will do the will do the to depress the to reduce the hypertension, the blood pressure. And two of them work very well. So at long last, we now allow it continue to manage it and see whether there will be growth adverse effect. There was none. So we okayed it. So I just told this question for other pharmacists to know. Yes, that the same the calcium channel blocker, they do different things. If you have an hypertensive patient and give only nimodipine, I don't think you achieve your goal in bringing down the blood blood pressure. So in our facility we do this and we get it result. Thank you.
Okay.
Hello. I want to make some comments.
Okay, Prof.
Okay, Prof.
Yes. Yes. Concerning the use of these calcium channel blockers, a patient who is hypertensive, remember that each patient is specific. You can use it for one patient and it works, but for the other patient, it does not work. But clinically, the two of them should not be used. You can use another drug. The other one is handling the neuro aspect. The one is handling because for some patients, you can use it. There are potential related drugs and then actual. For some patients, they may be having these side effects and some they will not have. You can give the same drug to two different patients and they react differently. So to be on the safe side, it is for you to look at the patients and monitor them and find out which one is good for patient A and which one is good for patient B. And that brings me to the use of what's that name? The NSAID. For patients who are hypertensive, we should not use ibuprofen because ibuprofen has water retention ability. And so it will worsen the hypertension. You can use any other, even though ibuprofen seems to be good from your results. But then it may not be good for every patient. There are patients who have chronically elevated BP due to fluid overload. So if you give this drug, it will worsen it. You can use other NSAIDs if need be. That's my own comments.
Thank you, Prof.
Thank you very much.
Thank you, Prof.
So over to you, Dr. Tim, if you're still on the call for the vote of thanks. Thank you.
All right. Thank you so much, the moderator, for standing in as the moderator, Dr. Rita. We also want to thank our wonderful presenters from Uganda. We really appreciate you so much for this presentation. We are particularly excited because this week was supposed to be a state presentation. We had Kano State that was supposed to do a presentation, and somehow we had a disappointment, and we had these volunteers from the education committee. So we want to really appreciate you. And the presentation is also timely. We really appreciate this present. And then also on the call, we have a lot of very wonderful people. I can see Professor Va Odili is on the call. Professor Chinwe Ukwetu is on the call. We appreciate our National SIPAN, chairman. We appreciate everybody that is present tonight. We really appreciate you on the call. All the NEC members that are present today, Professor Olaiwola, you are also there. We really appreciate you for being on the call today. We also appreciate the Education Committee Chairman, Pharmacist Former MOMA, for all you've been doing behind the scenes to make sure our presentations come out well. Our past National Chairman, Hapney, I can see on the call, we appreciate you. Pharmacist Uche Imo, we appreciate you also. Then all NEC members present, we appreciate you. And we are also calling on you to join us again next week, Friday. We'll be having a special edition presentation. So at this point, I'll call on one of us to lead us with the closing prayer. Let me call on Mrs. Quanta Roland. Ma, please, you have the floor. Lead us with the closing prayer. Thank you.
Thank you very much, Dr. Timi. Shall we pray? In Jesus' name, amen. Father, we thank you for tonight. We give you all the glory for the gift of life. We thank you for the privilege of health. We thank you for the Clinical Pharmacists Association of Nigeria. We thank you for our dear presenters and even the moderator, the education committee. We thank you for what we have learned tonight to add to our knowledge, so we'll be able to add more value to the lives of our patients and our clients. Even as we sleep, we commit our sleep into your mighty care, that we'll have a sweet sleep. We're looking forward to gathering again next month to learn, to add more skills and competencies and knowledge to what we have for the benefit of humanity. Thank you for SIPAN. Thank you for its members. Thank you for the resource persons. Thank you for all you're doing. You will continue to lead us from one step to the other and advance the cause of pharmacy profession. We give you all the glory. May your name alone be highly exalted. In Jesus' mighty name we pray. Amen.
Amen.
Amen. Thank you from Quanta Roland for that closing prayer.